So, as you know that proteins are synthesized inside the cytoplasm by the ribosomes, but they just don't stay there. They are transported to the various other locations inside the cell, such as the cell organelles or the cell membrane. Now we will see what is protein targeting and sorting. Protein targeting and sorting is the process by which the cell sends the proteins to the various locations, right locations. This is crucial for the cell to work efficiently. Now moving on, we will see why protein targeting is important. Each organelle inside our cell has some crucial functions for which they need particular proteins to do their job, and if the proteins do not reach to the correct location, this will lead to variety of diseases. Uh, for example, in Zellweger Syndrome, proteins fail to reach the peroxisomes. This will lead to severe metabolic problems, and we will discuss this in upcoming slides. Now we will see what functions does protein perform in various organelles. In nucleus, it will regulate gene expression and DNA replication. In mitochondria, it helps in ATP production and oxidative phosphorylation. In endoplasmic reticulum, it functions as ribosomes, translocators, ER chaperones, and enzymes for lipid synthesis. In Golgi apparatus, it functions as receptors, transport proteins, etc. In lysosomes, it functions as enzymes for breaking down cellular waste and membrane proteins. In plasma membrane, it functions as receptors, enzymes, translocators, and structural proteins. Now I will hand over the mic to Shilogna.
Concept of address labels. Protein possesses intrinsic signals which are also known as address labels, and which includes, first we have signal peptides, then we have targeting sequences, and then we have special chemical changes like post-translational modifications. So, what are address labels? They are specific amino acid sequences that guide their localization and ensure they reach the correct cellular compartments. Then we have the major pathways. So there are three types of pathways. First one is the co-translational targeting. So the proteins enter the ER while they are still being made. Then we have the post-translational targeting. So which is basically where the proteins are fully made in the cytosol and they then move to the different cell organelles like maybe peroxisomes or nucleus. Then we have the vesicular transport, which is basically where the proteins move between different organelles through small vesicles. So here's a flowchart like dedicating all the three major pathways for protein targeting. So firstly we have co-translational modifications. Targeting. So firstly, as a protein is being made by a special by the ribosome, then a single recognition particle SRP which binds to the single peptides. Then further translation is the process of translation is stopped by this SRP which brings the ribosomes to the endoplasmic reticulum. After that, again the process of translation resumes and the protein enters the ER like the endoplasmic reticulum through this channel which is known as a translocon. Then I will pass the mic to my next team member.
Post-translation targeting. While most proteins are destined for the endoplasmic reticulum are directed towards the organelles during their synthesis. The others are directed to their synthesis completely in the cytoplasm and then directed to the destination post-translationally. Post-translational targeting refers to the process in which proteins are completely synthesized, then they are directed to specific locations within or outside the cells such as membranes, the extracellular space and organelles. This targeting is crucial for proper protein functioning and cellular organization. Specific signals directs them to mitochondria, the N-terminal matrix targeting sequence, peroxisomes PTS1 and PTS2, and nucleus nuclear localization signals. This shows the post-translational pathways like the transport through nuclear pores, transport across membranes, and transport by vesicles. Nuclear protein inputs. Proteins that need to enter the nucleus have special signals, the nuclear localization signals, which are recognized by the importing proteins and helps them pass through the nuclear pods. These require energy, which are given by GDP hydrolysis using the RAN protein. Mitochondrial targeting. Mitochondrial proteins are imported after their synthesis. Entry happens through the complexes present on the membrane, that is TOM in the outer membrane and TIM in the internal membrane. Energy from ATP and membrane potential helps the protein unfold and pass into the membrane. I'll pass the mic to my next teammate to continue.
Next is peroxisomal targeting. Protein is going to the peroxisome and peroxisome have the peroxisomal targeting signal. Peroxisomal targeting signal on the C terminal end, it is the most common. Protein is entered through the help of the peroxin and it is a receptor protein. Any peroxisomal protein import defect will lead to the disease. Example, Zellweger Syndrome. Here is a diagram is represent the peroxisomal protein import pathway and the vesicular transport. After entering the endoplasmic reticulum, protein is going to the Golgi apparatus for the further sorting, and from the Golgi they can be go from the plasma membrane, lysosome and secretion outside the cell. Transport is done using the vesicle coated with the protein like COF2 from the endoplasmic reticulum to Golgi and coated protein 1 from the Golgi to the endoplasmic reticulum and clathrin from the Golgi to lysosome or the cell surface.
Examples of sorting signals. This segment mainly describes the specific signal sequence that direct the protein to the correct cellular organelle. Each cellular organelle have unique address level that tell the cell where a protein should go. So this is a chart of one side this organelle and other is signal type, like ER have N-terminal hydrophobic sequence and mitochondria N-terminal targeting sequence. For nucleus is NLS, nucleus localizing signal. For peroxisome it PTS1 and 2 and peroxisomal targeting signal 1 and 2. For lysosome is mannose 6-phosphate and Golgi membrane is diacidic sequence in membrane protein in COP2 vesicles. Then clinical relevance. First, Zellweger syndrome. Zellweger syndrome is a rare inherited condition that affects the body's ability to produce functional peroxisome. It is caused by mainly mutation the gene for peroxisomal protein transport. Peroxisomal protein with PTS1 and 2 signal sequence cannot enter the protein. As a result, functional peroxisome are not produced and toxic substances accumulated in the cell that affect the brain, liver or kidney, and that's why the Zellweger syndrome other called the cerebrohepatorenal syndrome. Next is eye cell disease, inclusion cell disease. It is mainly caused by mutation that affect the mannose 6-phosphate tagging to the lysosomal enzyme. If mannose 6-phosphate does not tag to the lysosome, lysosomal enzyme cannot enter to the lysosome. As a result, it's secreted out from the cell. So lysosome does not have any functional enzyme, and lysosome as digestion not occur in the lysosome. So undigested material accumulated in the cell, and so that's why the eye cell disease is called inclusion cell disease. Next is mitochondrial disease. This cell mainly caused by the mutation that affect the mitochondrial protein to correct to the mitochondrial protein import. That's why the mitochondrial protein cannot enter to the mitochondria. As a result, the ATP cannot produce properly. As a result, it affect mainly brain, heart, muscle. As a result, many symptoms like fatigueness, muscle weakness can occur. Next summary, we saw the all side and understand that protein targeting ensures the correct protein localization, and it uses signal sequence and receptor to be correct location, and it is vital for function and cellular health, and mistargeting can lead to the serious disease. Thank you.
Very good presentation. Very nice. Thank you. Any question? Next. Absent क्या है?
Sir, Tamanna Khatun.
Absent क्या है?
Roll number 139.
139.
9.
Bolo.
Good morning, respected teachers, HOD sir, and my dear batchmates. I am Tamanna Yasmin, and I am honored to present today's topic with my teammates Ronak, Surya, and Tamal. Today, we will be presenting a very important diagnostic tool, that is renal function test or RFTs. Through this presentation, we aim to provide a clear and concise overview for renal function test. We hope this session will be engaging and informative for everyone. Let's begin our presentation. What are RFTs? RFTs are groups of biochemical tests helps to assess how the kidney is performing their function. RFTs also help in detection and maintenance of acute and chronic kidney disease as well as systemic conditions like diabetes and hypertension. Now let's go through some functions of kidneys. The main function of kidney is excretion of nitrogenous waste like urea, creatinine and uric acids. Kidneys also help in water electrolyte balance and excretion of hydrogen ion for pH balance. Kidneys also have endocrine functions like vitamin D activation and erythropoietin productions. On an average, our kidneys filtrate about 180 liters of water every day, out of which 178.5 liters is reabsorbed along with all the glucose and amino acids and most of the electrolytes. Now, classification of renal function test. Renal function test is broadly classified into screening of kidney disease and to assess renal function. Under screening of kidney disease, we have 3 parts: complete urine analysis, serum non-protein nitrogen or BUN, and test for serum electrolytes. To assess the renal function, again there are 2 groups: assessing the glomerular function, which includes GFR, clearance tests, and glomerular permeability. And assessing the tubular function, we have 2 tests: concentration test and dilution test. Urine analysis. Routine urine analysis is again grouped into 3 parts: physical examination, chemical examination, and microscopic examination. Chemical examination involves, we look for 24 hours urine output, appearance like color, then pH, order of the urine, and specific gravity and osmolarity. This helps identifying the hydration status, diet, or kidney disease. Chemical examination. The chemical examination has to detect abnormal constituents present in the urine, like protein, blood, glucose, ketone bodies, and bilirubin. This helps identifying any kidney disorder or metabolic disorder. Now I would invite Ronak to continue with the presentation.
Now we come to serum non-protein nitrogen. These include urea, creatinine, uric acid, and other minor substances such as urobilinogen, indican, ammonia, amino acids, etc. The major route of excretion of these compounds is urine. In kidney dysfunction, the levels of these compounds are elevated in plasma. Normal range in serum, it is 0.7 to 1.4 milligram per deciliter in case of males and 0.4 to 1.3 milligram per deciliter in case of females. Serum creatinine increases in glomerular nephritis, renal failure, and dehydration. Now, blood urea nitrogen or BUN. It measures the amount of nitrogen in the blood that comes from urea, a waste product of protein metabolism formed in the liver and excreted by the kidneys. Normal range, serum urea, it is 14 to 40 milligram per deciliter, and blood urea nitrogen, it is 7 to 20 milligram per deciliter. Blood urea nitrogen is elevated in renal failure, dehydration, high protein diet, and decreases in liver disease and malnutrition. Now we come to serum electrolytes. Normal ranges of serum electrolytes.
Sodium, it is 135 to 145 millimole per liter. Potassium, it is 3.5 to 5 millimole per liter. Chloride, it is 98 to 106 millimole per liter. And bicarbonate, it is 22 to 28 millimole per liter. Estimation of non-protein nitrogen along with electrolytes, that is sodium, potassium, and assessment of acid-base balance are used as a panel of tests to indicate the abnormalities in the kidney function. Now, GFR, that is Glomerular Filtration Rate. GFR provides a useful index of the status of functioning glomeruli. GFR cannot be measured directly. It is estimated with the help of a filtration marker, example inulin. Normal GFR for young adults is 120 to 130 milliliter per minute per 1.73 square meter of body surface area. Now, grading of chronic kidney disease on the basis of GFR. We do total 5 gradings on the basis of the GFR value. If the GFR value is greater than 90, we mark it as grade 1. If it lies between 60 to 90, it is grade 2. If the GFR value is less than 15, we mark it as grade 5, which is nothing but kidney failure. Now I will request the next member. Continue.
কপি করেছিস তো কপিতে তাহলে থাকার কথা কপি মানে তো আছে
My part of discussion is clearance test. Clearance is defined as the quantity.
কপি পেস্ট তো তাহলে থাকার কথা
একটুকু আমরা মানে কিছু চেঞ্জ
হ্যাঁ?
করেছি
চেঞ্জ করেছিস
মানে ভ্যালুগুলো চেঞ্জ করিনি আমরা জাস্ট একটুকু মানে ল্যাঙ্গুয়েজ
না না আমি ওইটা বলছি না এই যে যেটা ওই গ্রেডেশনটা দেখালো গ্রেডেশনটা তো কপি পেস্ট করা
কপি পেস্ট
বাসুদেবন from বাসুদেবন
Positive. So my part of discussion is clearance test. Clearance is defined as the quantity of blood or plasma is cleared of a substrate per unit time, and x-rate is milliliter per minute. Clearance tests are used to measure GFR by filtration markers. Filtration markers are substrates that are freely filtered through glomerulus. It is neither absorbed nor secreted by renal tubules. Now there is a formulation for clearance rate. The clearance C equal to U into V by P, whereas C indicates the represents the clearance rate, U represents the concentrations of substrate in the urine, V represents the urine. V indicates the urine flow rate, and P indicates the concentration of the substrate in plasma. Now there are 3 types of clearance test. One is inulin, the second one is creatinine, and the third one is urea. We will discuss one by one. The inulin clearance test. Inulin is a polysaccharide of fructose, which is used to measure GFR, and it is freely filtered, not reabsorbed, not secreted, and not metabolized in the kidneys. Values found in healthy adult is nearer to 125 ml per minute. That is why it is ideal for GMR estimation, but rarely used in clinical practices as
মাইকটা কাছে
clinically due to process of the administration is exogenous and it is time consuming. Now it is largely replaced by creatinine clearance test for routine purposes. Now we will discuss about creatinine clearance. The creatinine is endogenously produced, freely filtered, and minimally secreted by kidneys. Its fixed amount of creatinine is produced and released into circulation every day depending on the muscle mass. Reference interval of serum creatinine is 0.5 to 0.9 mg per dl in females, and in males it is 0.6 to 1.2 mg per dl. The higher value in males is due to the increased muscle mass. Values found in males is 90 to 115 ml per minute, and females for 85 to 110 ml per minute. Now urea clearance test accesses the kidney's ability to filter and excrete urea. It is a waste product of protein metabolism, less accurate than creatinine clearance, but is freely filtered, 40% reabsorbed, and also affected by protein diet. Now there is cystatin C. Cystatin C is a low molecular weight protein produced by all the nucleated cell. It is freely filtered through glomerulus, not secreted, not reabsorbed, more sensitive and reliable than creatinine for detecting early kidney dysfunction, and not affected by muscle mass, age, gender, or diet, unlike creatinine.
So till now we were talking about GFR and the clearance tests. Now we will move on to the next topic, that is test for glomerular permeability. So we do perform glomerular permeability test to assess the integrity of glomerular filtration barrier. Normally, the glomerulus filters out large proteins like albumin and prevents it from passing into the urine. But there are some abnormalities like proteinuria, especially albuminuria, where some traces of albumin can be found in urine. Under glomerular permeability test, there are some common tests like heat acetic acid test, sulfosalicylic acid test, dipstick test, 24-hour urinary protein estimation test, and microalbuminuria test. The microalbuminuria test can be an early marker of glomerular damage. Then we will talk about albumin excretion rate. As the name says, AER, that means albumin excretion rate, it is the amount of albumin that is excreted in urine per unit time. Usually it is measured in micrograms per minute or milligram per 24 hours. Since our 24 hours urine collection for AER is tedious, so what we do, we take albumin and creatinine ratio. Now we will talk about albumin-creatinine ratio. It is measured in a spot urine sample, typically in the first morning void. Normal ACR for men comes less than 17 milligram per gram, and for women it's less than 25 milligram per gram. But there are some abnormalities like microalbuminuria, where the values exceeds from 30 up to 300 milligram per gram. It can be indicative of diabetic mellitus or hypertension. And if the value exceeds 300 milligram per gram, it can be a case of macroalbuminuria. Now we will talk about the tubular function tests. So, tubular function of the kidney refers to the tubules' roles in reabsorbing the essential elements and excreting out the waste products into the urine. It helps in maintaining the electrolyte, water and acid-base balance of the urine. So, two tests we perform here. First, concentration test and then the dilution test. So, first one, the concentration test. We tell the patient to eat at 6 p.m. and then to fast overnight. No food or water should be taken in the course of this full night. And then the next morning at 7 a.m. the bladder is emptied and the urine is discarded. A fresh urine sample is collected at 8 a.m. for analysis. And we analyze the specific gravity and osmolarity of this sample. Normally, if the kidneys are functioning well, the value of specific gravity should come greater than 1.022 and the osmolarity should be greater than 850 milliosmol per kg. But in some case of renal impairments like tubular dysfunction and isocynuria, the specific gravity remains fixed around 1.010. The osmolarity falls down to 300 milliosmol per kg, and this can be indicative of diabetes insipidus. And then, last but not the least, the dilution test. No water should be taken after midnight, and then the next morning at 7 a.m. the bladder is emptied and we give 1.2 liter of water to the patient in every 30 minutes interval. And hourly urine samples are collected for next 4 hours. The volume, specific gravity and osmolarity are measured. Normally, the most water load is excreted within 4 hours. So, the specific gravity should drop under 1.003 or osmolarity to 50 milliosmol per kg. This test is more sensitive and safer than the concentration test because the patient don't have to fast overnight, right? Then I would like to conclude the topic by talking about some diseases and the RFT abnormalities found in them. First up, the chronic kidney disease. Here the serum creatinine levels are elevated, blood urea nitrogen levels are elevated, there are fall in GFR and protein in urine can be found, and isocynuria. In acute kidney injury, sudden increase in creatinine and blood urea nitrogen will be seen, and there will be fall in GFR and urine output. In diabetic nephropathy, microalbuminuria will lead to proteinuria, and along with this, there will be high ACR value with fall in GFR. Now, in hypertension-induced nephropathy, there will be an increased blood urea nitrogen value along with increased creatinine and protein in urine. In glomerulonephritis, blood in urine, that means hematuria, proteinuria, that means protein in urine, fall in GFR, and RBC casts in urine should be found. In nephrotic syndrome, there will be heavy proteinuria, hypoalbuminuria, and edema will be seen. In urinary tract infection, pyuria, that means pus in urine, bacteriuria, that means bacteria will be found in urine, and mild proteinuria can be seen. And there will also be WBCs in urine. Thank you.
A good presentation. You all have prepared very well.
Yes, sir.
Okay. Any question? Sir?
Whatever you have said, have you understood everything? Now, what is the importance of NPN in urine? What is the actual importance of NPN? NPN you have said, what is first and foremost, what is blood urea nitrogen? What do you mean by that? What is the difference between urea and blood urea nitrogen? Basic question. Clarify, what is the difference between urea and blood urea nitrogen? জানলে বলো, না জানলে ভুল বলো না গো। দুটো প্রমাণ হয়ে যাবে। If you do not know the answer, do not try to ও আগে কনসেপ্টটা আছে কিনা ঠিক আছে দেখো তুমি দেখো না জেনে লিখছো না there are many things what you have written. I am sure that you don't know the meaning. What is RBC caste? If I ask you what is RBC caste, you don't know the meaning. You have written what I want to know, basically whatever you are writing, at least this part you must know each and every point very clearly, and that is basically for your own self development. Now you don't know the difference between the BAN and urea. So if I say I will measure urea and not BAN.
There are few terms like polyuria, oliguria, anuria. Can you tell me that how do you distinguish? বলো
স্যার পলিইউরিয়া ইউরিনেশন বেশি হবে।
হ্যাঁ সেটাই বুঝলাম, অলিগুরিয়া কম হবে, অ্যানিউরিয়া একদমই হবে না, কিন্তু কন্ডিশনে আমি কতটা ml হলে হবে সেটা তো তোমাকে বলতে হবে।
1.5 to 2 liters. 1.5 to 2 liters per day. Volume will increase in 24 hours. More than 2 liters per 2 liters per.
So see, these are the things like you should answer, okay, when you are reading this particular chapter. Number one. Number two, you have discussed the clearance test. The clearance test, a number of compounds are used for clearance test. But why do you choose creatinine over all of them?
Sir, because creatinine is not reabsorbed like urea, So we use creatinine, and in case of inulin, we have to give inulin from outside, and creatinine is produced inside our body.
Okay. So in inulin, actually, we cannot do the test with the pediatric patient with inulin. Nowadays, instead of giving any of these, we have another method for measuring this clearance value. Can you name that method?
So cystatin C.
Cystatin C. Anything else? A radioactive element is used. Chromium 51 EDTA clearance test. Here another test is there. Hippuric acid clearance test, urea clearance test. All these are important. For what? These are all not used for only filtration test for kidney. They are used for multiple other functions of kidney. Okay. So anyway,
See, what is the formula of urea? What is the formula of urea? Can anyone volunteer? CONH2 whole 2. How much of nitrogen is there? 2 nitrogen. You just calculate the molecular weight.
60.
60, out of which nitrogen is 2, that is 28. So blood urea nitrogen means 28 by 60. So that was used in the earlier days. Now we are not doing basically blood urea nitrogen, we are doing urea. So you see, well, on a lighter mode, there is a huge argument in the laboratory. One patient was basically created a ruckus in the department that, please explain what is creatinine. I understand urea. I know that he doesn't understand urea also. Now there is a uproar, furious condition, and that particular patient was dragged to my chamber, asked that, sir, we failed to explain what is creatinine. Sir, please explain. What answer I gave to that particular patient. This type of situation you will face. Patients without knowing anything will harass you and target you to answer something. And you must tell in that situation in some form that they will not understand. The answer which I gave is that it is an anhydride of guanidinic acetic acid. Do you understand? Immediately person said, okay, get out.
Good afternoon, respected teachers. Today, me and my team is here to present on the topic of proteinuria. So, what is proteinuria? Proteinuria, this term denotes the abnormal presence of protein in urine. The normal physiological conditions, the amount of protein is minimal. Typically,
talk to the mic.
Sir? The amount of protein in urine is minimal, typically 150 milligrams per day. Proteinuria is also an indicator of critical health disease or systematic disease. Proteinuria, the presence of abnormal protein, is a clinical finding that can range from benign and transient conditions. It is also a significant indicator of severe kidney damage or underlying systematic disease. Now let us understand the normal kidney function and protein filtration. The filtration process occurs in the glomeruli of the kidney. It contains intrinsic filtration barriers. These tiny filters are designated to prevent large protein molecules to pass in the urine from the blood. The glomerular filtration barrier consists of three layers. First, the fenestrated glomerular endothelium. Second, the glomerular basement membrane. And third, the special epithelial cells called podocytes. This barrier imposes restrictions based on both size or weight and also electrical charge. The presence of polyanions on the glomerular capillary wall creates a net negative charge. This negative charge repels away the negatively charged proteins, such as albumin, and this prevents the albumin from going into the urine from the blood. Under normal circumstances, the kidney mechanism and reabsorption ensures less than 150 mg of protein is excreted in urine over a 24 period of. So,
how many types of proteinuria are there? There are different kinds of proteinuria. And the first one, glomerular proteinuria. This happens due to the damage in the glomerular filtration barrier. It is also the most common type of proteinuria that occurs. In this kind of dysfunction, 2 grams of protein is usually excreted normally in 24 hours. But in severe cases, more than 3.5 grams of protein is excreted. The next one is tubular proteinuria. In this, the dysfunction occurs in the proximal renal tubules. In these cases, the normal small proteins which are usually filtrated out is not reabsorbed and hence they excrete in the urine. And this is typically less than 2 grams of protein is excreted out, and this is a less severe case of proteinuria. The other kind of proteinuria is overflow proteinuria. In this, there is an excessive production of low molecular weight proteins, plasma proteins, which are excreted through urine. A classic example of this is benzose protein in multiple myeloma. Now I shall pass the mic to.
It is a type of proteinuria. It is albuminuria. So what is albuminuria? Albuminuria is a pathological condition where we can find elevated amount of albumin in our urine. Normally there is a certain amount of albumin protein in our urine, that is less than 30 milligram albumin per 1 gram of creatinine per day. So if we want to know about albuminuria, we should know about albumin protein little bit. It is albumin protein is abundant, is most abundant protein in our blood plasma, and it is synthesized in our liver. It plays an important role in maintaining of osmotic pressure, oncotic pressure in our blood, and it is a transporter protein of certain types of steroid hormones, certain type of drugs, and bilirubin, and some kind of ions like calcium. It is a chronic kidney disease which may be caused by the diabetes, hypertension, or some kind of inflammatory kidney diseases. In this chart, we can see the normal amount of albumin in our urine is less than 30 milligram per day. If it is a little bit elevated, it is called microalbuminuria, that is 30 to 300 milligram per day, and it is severely elevated, then it is called macroalbuminuria, which is more than 30 milligram per day. It is another kind of proteinuria, which is myoglobinuria. It is what is at first know what is myoglobin. Myoglobin is a protein kind of hemoglobin. We can find it in our muscle tissues, and it transport oxygen. If there is any tear up of muscle, we can the myoglobin came out in blood, and then it is filtered by the kidney. So myoglobinuria is a pathological condition when the muscle tissue is tear up, and we can find myoglobin in our urine. So it is a nephrotoxic. It is a nephrotoxic substance because myoglobin destroy the epithelial cells of kidney tubules. It is common in our crush injuries and some kind of drug toxicity, extreme exercise, seizures, and a viral infection, myositis. In this chart, we can see the normal level. Normally, the myoglobin in urea is absent. The mild myoglobinuria is less than 100 microgram per ml. Moderate myoglobinuria is 100 to 500 microgram per ml, and severe myoglobinuria is greater than 500 microgram per ml. Now I am handovering my mic to Trishita.
Moving on to the causes of proteinuria. So there are transient benign causes of the proteinuria. So mainly strenuous exercises or heavy lifting exercises, dehydration, fever, stress, any pregnancy, exposure to the extreme cold, orthostatic proteinuria, and highly alkaline urine. Moving on to the primary kidney diseases. There are chronic kidney disease, diabetic nephropathy, IgA nephropathy, membranous nephropathy, Nephrotic Syndrome, glomerular nephritis, and focal segmental glomerular sclerosis. Moving up to the systemic disease and the other factors which are affecting. There are almost hypertension, diabetes mellitus type 1, type 2, heart disease, lupus nephritis, multiple myeloma, certain drugs like NSAIDs, and infections like the HIV, hepatitis B or C, and can be malaria, and dyslipidemia, inflammatory cytokine, and rheumatoid arthritis. Moving up to the most important part, which is the clinical manifestation of proteinuria. It is early stages of the proteinuria, often present without noticeable symptoms. Which is the early stage, we don't find much symptoms, but when it is in the when the kidney degrades, then we find there are severe proteinuria symptoms like foamy or the bubble urine, which is due to the protein lowering surface tension. Also the swelling or the edema, which is particularly happening in the hand, leg, ankle, in the abdomen or under the eyes, which is happening because of the fluid retention due to the low blood albumin. Also fatigue, dry skin, numbness, also bloody urine. There can be changes in the urine patterns, urination patterns. It can be polyuria or the oligouria also, and there can be loss of appetite, weight loss, muscle cramps, nausea, vomiting. There can be shortness of the breath, sleep problem. There can be thinking criticality, and these are often present in the chronic kidney diseases also. Now the next member should take over the slide.
Now after clinical manifestation, we are moving to the test for proteinuria. So the first one is the urine dipstick test. It is a qualitative test where we cannot know the exact amount of protein present in the urine. It gives the rough idea whether the protein is present in urine or not. It mainly detects the albumin protein, as it is the main plasma protein in our body. Now how the result is given. The color change in the strip is compared with the standard strip, and we can give the test results. If the negative test is came, then no protein is present in the urine. For the trace, there is small amount of protein present in the urine. For +1, it is very mild proteinuria. For +2, it is moderately proteinuria. And for +3 or +4, it is severe proteinuria. This test has pros and cons too. Advantages like this test is very much cheap and very quick and easily can be performed easily. And disadvantages like it cannot reduce the microalbuminuria, as very less amount of albumin is present in the urine, and it is also affected by the urine concentration. So the second one is the spot urine protein to creatinine ratio. It is a quantitative test where we can measure the total protein is to creatinine ratio from a single urine sample. We can where the normal range is less than 0.2 for adults, and in case of proteinuria, it goes up to above than 0.3. For the third test, it is a spot urine albumin to creatinine ratio. It is also a quantitative test. It is mainly done in case of diabetic patients and early CKD patients. It gives the result. The normal range is less than 30 milligram per gram, and if the result is between 30 to 300 milligram per gram, then it is microalbuminuria, and greater than 300 is the macroalbuminuria. It has its own advantages, like this test is very much accurate, and it can be performed by the single sample of urine, and it is unaffected by the urine concentration like the dipstick test. And for the fourth one, the 24-hour urine protein collection. It is considered as the gold standard for the quantitative protein loss. because it gives the accurate amount of protein present in the urine. Um, the procedure is very much simple and straightforward. The patient has to collect the entire urine throughout the day, and the protein present in that is to be calculated. For the normal condition, less than 150 milligram per day protein is to be present in the urine. But in case of nephrotic range, it goes up to greater than 3.5 gram per day. But it has downside too, because the patient has to collect each and every drop of urine throughout the day, and it is very much time consuming and prone to error. For the fifth and the last one, it is the sulfosalicylic acid test. It is a confirmatory test for non-albumin protein. It gives a total idea of protein present in the urine. In multiple myeloma case, there is excessive production of the Baines-Jones protein, and this test can also deduce that kind of unusual protein in the urine. If the initial tests are positive, then we can move forward to the follow-up tests like renal function test for the serum creatinine and GFR, and the blood pressure monitoring and imaging of kidney, and serologic tests if glomerular nephropathy is present. Now I am handing over to my fellow teammate.
Next, we have the management for proteinuria, which includes the first one to speak about is the lifestyle modifications. We would include a less sodium restricted diet because it lowers blood pressure, prevents kidney damage, and thereby the proteinuria would be controlled. Next, we have moderate protein intake. The optimum protein intake is 0.8 gram of proteins per kg of body weight per day. It would prevent the increased kidney burden. Next, we have blood sugar control for diabetics by inducing a fiber-rich diet which can include fruits, vegetables, nuts, legumes, and seeds. High blood sugar damages the vessels of the kidney, which would cause proteinuria. So tight glucose control, it reduces proteinuria. Then we have some general health recommendations like regular exercise, cessation of smoking, and weight management to reduce the risk factors. Next, talking about the pharmacological interventions. First, we have SGLT2 inhibitors. SGLT2 is sodium glucose co-transporter receptors present in the proximal convoluted tubule of the kidneys, which is used for reabsorption of filtered sodium and glucose. These inhibitors, like for example canagliflozin, it would reduce the reabsorption of sodium and glucose, and thereby sodium would accumulate in the macula densa, giving a tubular glomerular feedback, which would decrease the intraglomerular pressure, and thereby it's renal protective. Next, we have angiotensin converting enzyme inhibitors like captopril or angiotensin receptor blockers like valsartan and telmisartan, which are considered as the first line of therapy. They reduce proteinuria either like for angiotensin converting inhibitors, it prevents conversion of angiotensin 1 to angiotensin 2. Angiotensin 2 being a vasoconstrictor, its decreased levels would reduce the intraglomerular pressure of the kidneys. Next, we have finerenone, which is a selective non-steroidal mineralocorticoid receptor antagonist. It would reduce the effect of aldosterone on the kidneys. It also offers anti-inflammatory and anti-fibrotic benefits to prevent scar tissue damage of the kidneys. Next, other adjunctive therapies include diuretics like furosemide thiazides for edema, statins for dyslipidemia, and immunosuppressants for autoimmune kidney disease based on the underlying cause. Next, monitoring. Regular monitoring is very much recommended to assess the ongoing kidney function, the proteinuria levels, and to adjust therapy according to it. People who are at risk. Individuals with a certain predisposing factors are at a higher risk, who include the people who have family history of kidney disease, of diabetes, high blood pressure, heart disease, obesity, and cigarette smoking. Thank you so much.
Thank you. Preparation the slides were good, but I think you have overtold, this much is not required in first year. Correct? Because you have no idea about the compounds you named. Do you? If I ask you any question regarding any of the compound you named just now, can you answer a single set?
A little bit I can.
Yes.
Transporter पर काज करें HgL2 inhibitor
Proximal convoluted tubules of kidneys. So which I don't know.
So when you go for management and treatment, there are so many things you have to tell. Okay, some contraindication there for every drug to provide. There are some contraindication. You cannot use drugs like just like that. So it's better to avoid in first year. Otherwise, this is good, fine. So nice presentation. Thank you.
Thank you, sir.
First question, first speaker. You said albumin is negatively charged and there is polyalanine on the base membrane. Why albumin is negatively charged? There is one slide where you have categorically mentioned that glomerular basement membrane is having polyanions and albumin is also negatively charged. Was the sentence correct?
Sir, the polyanions.
Will you go back to the first slide, that slide? Rajini, একটা slide back করে দাও, back করে নিয়ে যাও তো। Whether it was a correct statement, and if it is so, you justify. If it is a wrong statement, then also you acknowledge. जाओ, Aye. Read the sentence. On the capillary wall, it creates a negative charge. This negative charge acts as a crucial electrostatic barrier, repelling negatively charged proteins like albumin. Was it a correct statement? And if so, why? And that is what I am trying to emphasize, that you have written but without understanding what you have written. Why albumin is negatively charged? Straight cut question. The answer statement is correct. Whatever you have written is correct. Now at this level, these are the basic biochemistry question I am asking you.
What is the pH of blood? They are saying. What is the pH of blood?
7.35.
So what do you expect the charge should be? Would be a protein in the plasma of that pH.
What is pK value? These are the basic questions will be asked.
So this above is PI. The pH of blood is above the PI of albumin. Hence it is negatively charged.
You understand?
Like 4.6. Then albumin can be positively charged. What is the PI of albumin?
PK.
PI of albumin?
PK. Right.
4.6. 4.6. That means 4.6 is, it has no net charge. Zero. So at 7.4, all the serum proteins, that means plasma proteins, are negatively charged. So if any inflammation occurs in the nephrotic membrane, then this charge alters, and hence albumin appears in the urine.
Okay.
And this is regulated by hypertension. If the person is suffering from hypertension, then excessive pressure plus charge resolution, appearance of albumin in urine.
Second question to second speaker. Why you have said myoglobin? Okay. Why myoglobin appears in the urine, not hemoglobin? You said myoglobinuria. Hemoglobin can also appear. What is the problem of hemoglobin from appearing in the urine? Why normally even if there is myoglobinuria is an indicator? देखो बेसिक क्वेश्चन एगुलो एकदम एगुलो बायोकेमिस्ट्री क्वेश्चन एक तो বক বক করছিস জিজ্ঞেস করছিস যেটা সেটা শুনছিস না কোশ্চেনটা এই বেসিক কোশ্চেন জিজ্ঞেস করা আছে এগুলি জিজ্ঞেস করা হবে পরীক্ষাতে ইরিটেট করছিস না এইজন্য খুব রাগ লাগে
Having mass, protein has the myoglobin. So which one is bigger inside?
So usually 67,000 is the
Which one should appear in the urine?
hemoglobin is
সেই বেরোবে তার মাইক্রোবিউল 17,000 হ্যাঁ বল এইগুলো কোশ্চেন যে এগুলো বেসিক কোশ্চেন জিজ্ঞেস করা হবে
The same range. That is why they appear in the urine.
The third speaker.
So when you read biochemistry, you read these things. Gather information, gather insight about these things.
Third speaker, you said also proteinuria. What is the difference between albuminuria and proteinuria? At one point of time, we were talking about albuminuria. And okay, second question. You said about microalbuminuria and macroalbuminuria. Is the size of the albumin increased? Size of the albumin is increased or decreased? In microalbumin, is the size of the albumin?
So the amount of albumin.
Amount of albumin. So not the size. What is the difference between albuminuria and proteinuria?
Sir, the major proteins which are relying is the albumin. That's why protein means that there can be any kind of protein. It can be any protein, but albuminuria means only albumin is only present over there.
And what about proteinuria? You said
Any protein can be present. Any protein can be present.
Any proteinuria.
Albumin, no globulin. Myoglobin. Albumin, myoglobin.
মায়োগ্লোবিন হবে না মায়োগ্লোবিন মাসল লেভেল হলে হবে অ্যালবুমিন নাও আসতে পারে
Hemoglobin is
অ্যালবুমিন না হিমোগ্লোবিন হতে হিমোচুরিয়া হবে glomerular membrane basement membrane that pore size is very important when the pore size is large larger molecular weight protein will also appear so albumin is the almost smallest amount which actually is prevented from appearing now any amount when the pore size is increased due to any cause the proteins which are having higher molecular weight will also start appearing